Hi, my name is Katie Connor. I've been working in PA education for about 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. Welcome to the Pediatrics review. This is a beast of a review with about 200 PowerPoint slides to prepare you for your didactic course in pediatrics, your pediatrics rotation, and your pediatrics board questions. One quick note before we start. If you've purchased any of the other reviews, know that this one is specifically formulated to be targeted at the 18 and under population. So all of the presentations, the workups, the diagnosis and treatment will be specific for the pediatric population. A lot of objectives to cover in this PowerPoint, and in the first part of this video, we're going to focus on the general wellness, the assessment of the infant, the wellness child checks that range all the way up to age 18. The second part of this PowerPoint will focus on all of the pediatrics related disorders in all of the subject areas that are listed here. Let's start off with the general wellness. The first thing that we're going to talk about is the Apgar score, and this stands for certain characteristics. The Apgar score is taken at 1 minute after birth and 5 minutes after birth, and it's a way that we can use to assess the infant. The higher the score, the better the prognosis for the patient. A score of 7 to 10 means that infant is in excellent condition. A score of 4 to 6 means the infant is moderately depressed, requires close monitoring and potential intervention. And a score of 0 to 3 means the infant is severely depressed and requires immediate resuscitation. The first A in Apgar score stands for appearance or skin color. The P is for pulse. G is for grimace or reflex irritability. The second A is for activity or muscle tone, and then R is for respiratory effort. In each of these categories, we're going to assign a point value, 2 being the best, 0 being the worst. For appearance, we would award a point value of 2 for a pink child, they're well perfused, 1 for peripheral cyanosis, and 0 if the child is blue or cyanotic. For pulse, over 100 is 2 points, under 100 is 1 point, and then no points for no pulse. Grimace or reflex irritability, if the child coughs, sneezes, or pulls away from a stimulus, that's 2 points. A grimace only is 1 point, and then no response to the stimulus is no points. Activity or muscle tone, if they're actively flexing and extending, that's 2 points. Some flexion would give you 1 point, and then a flaccid infant would give you no points. For respiratory effort, if they've got a good vigorous cry, that's 2 points. Weak irregular cry is 1 point, and then no cry is no points. The way that you will see the Apgar score on your test is they will give you certain characteristics in each of these categories, and they will ask you to calculate that Apgar score. Next, we're going to move on to birth and routine nursery care and the assessment of that infant. At birth, the first thing that should happen is should be suctioning of the mouth that prevents aspiration. This can be done with a bulb syringe, a DeLee trap, or a suction catheter. Then we will clamp and cut the cord and dry that infant immediately to prevent any heat loss. The child will then be transported in a head down position to allow for brain perfusion, airway opening, and secretion drainage. They're going to be placed supine under an overhead heater. And then the next part, our routine nursery care, our assessment is going to happen. The first thing that we would measure would be vitals. These are the vitals for an average infant. Heart rate of 120 to 160 beats per minute, respirations of 40 to 60 breaths per minute, temperature of 36.1 to 37 degrees Celsius. And then we're going to take some standardized measurements. Crown to heel length on average is 47 to 50 centimeters. The head circumference at the widest part would be 33 to 35 on average. Chest circumference at the nipple line, 30 to 33 centimeters, and then weight 2.5 to 3.5 kilograms. We will also then take a measurement of the blood glucose. The first thing that we're going to do is administer vitamin K to this infant to promote clotting factor synthesis. Then we will administer the first in our series of hepatitis B. And then we will administer erythromycin or silver nitrate ointment to the eye. This is protective against any potential transmission of chlamydia or gonorrhea during the birthing process. The newborn heel prick test. This is taking a blood sample from the infant and sending it off for genetic analysis. The tests that are included in this vary by state, but commonly they're checking for diseases that, if caught early, are very treatable. Phenylketonuria, hypothyroidism, maple syrup urine disease, sickle cell anemia, cystic fibrosis, galactosemia, adrenal hyperplasia. These are all common ones. And then there's some that are included, again, in different states. The meconium is the first feces. This is something that in a post-term infant may happen in utero, but in a normal infant, it will be sticky, odorless, green and black, and it will pass 8 to 24 hours after birth. The urine in an infant will always be dilute because the kidneys have not matured yet. The final thing that we're going to do in that assessment is estimate gestational age. Are they preterm, are they term, or are they post-term? There's two different categories that we look at with this. The first one is going to be the neuromuscular category. And you're going to see that I'm going to put up some images here. Anything that is in red is indicating that it's a preterm infant. Anything that's green would be term or even post-term. First thing we'll do is look at their posture. Immature infants are always in an extended posture, whereas a mature infant is going to be in a flexed posture. The next square window refers to flexion at the wrist. Less flexion is more mature, and the more flexion is more mature. Arm recoil, extending the infant's arm out and looking for the amount of recoil into flexion. Remember that immature infants like to stay extended, whereas mature infants will recoil into flexion. The popliteal angle is taking the leg and moving it back towards the head and measuring for that first area where you feel that muscular resistance. Remember that term and post-term infants will have good muscle tone, whereas preterm, they will have less muscle tone. This scarf sign is pulling the arm across the body and feeling for that time when resistance is first met. And then finally, the heel to ear, bringing the heel back to the ear and feeling for that time when resistance in the muscles is first felt. The less resistance, the less mature the infant. The second category that we'll look at is physical. And this is just a fast assessment looking at this infant. We're going to go into a more detailed assessment in just one moment here. The first thing that we'll look at is skin. In an immature infant, the skin is transparent. In a term infant, it's pinkish, and then in a post-term, it's kind of ruddy and cracked and red. Lanugo is downy fine hair that is much more common in preterm infants, and we lose that as we get to term and post-term infants. Looking at the plantar or the foot surface, the creasing in that area, the less creasing that you have, the less mature infant. The breast tissue can range from imperceptible in an immature infant all the way to a fully developed areola in a mature or a term or a post-term. The eye in an immature infant can be fused shut and the ear will be very soft, whereas in a term or a post-term, it will be stiff and that cartilage will be stiffened. In the genitalia in males, immature males will have a flattened scrotum, mature will have two testes, and they will have deep rugae in the scrotum. In females, in an immature infant, you will have a flattened labia with an enlarged clitoris, and then in a mature infant, you will have the labia majora that is covering the clitoris. Next, I want to take you through a detailed assessment of the neonate. And the way that I've divided this out is into what are normal findings and what are abnormal findings in each of the area that we're assessing. Let's start off with the skin. In the normal skin findings of the infant, vernix caseosa, this is a removable white coating. We call it nature's cold cream. Jaundice is normal from 2 to 5 days old. Prior to 2 days, that is considered pathologic. Milia are immature sweat glands on the nose, and they are papules on the nose and the cheek. Erythema toxicum neonatorum sounds like it would be bad, but it's a blotchy red rash that's diffuse all over the body. It's self-resolving. It is benign. Neonatal pustular melanosis is in dark-skinned infants. They form little blisters that turn into dark spots that will self-fade. Other benign findings, a Mongolian spot is bluish or bruised in coloration. Nevus simplex is an angular red mark that's usually lighter red, whereas a port wine stain is a diffuse burgundy red. It's commonly on the face and the hands. Lanugo, we mentioned, is more common in preterm infants. Petechiae, if you had a very traumatic labor, can be around the back and the chest because that's the widest area of the infant. And then desquamation, the skin that they had while they were in utero will start to peel and shed away. That's all very normal. Abnormal findings, central cyanosis or acrocyanosis, that tells us that there was something wrong with the heart or the lungs. Jaundice at 1 day old, remember 2 to 5 days is normal, but 1 day old is indicative of hemolysis, ABO incompatibility, Kriegler-Najjar, hepatitis, or biliary atresia. A cafe au lait spot is a lightish kind of coffee-colored macule that can indicate neurofibromatosis. A hypopigmented or very light-colored ash leaf macule can indicate tuberous sclerosis. Next, we'll move to the head. Normal findings in the head. The sutures are open, the skull sutures are open, they can overlap. A pulsatile anterior fontanelle is normal. Molding or cone shape, if they had a vaginal birth, is very common. Caput sexadeum is edema in the scalp. Cephalohematoma is bleeding under the periosteum that does not cross the suture line. Craniotabes, they describe this as kind of a ping pong ball. It's a brittle, thin bone in the occipital and the parietal area, and if you push in on it, it will collapse and then it will pop back out. So they describe this as a ping pong ball. You push it in and it pops back out. Abnormal findings in the head, microcephaly or macrocephaly. Craniosynostosis, where you have a premature closure of the sutures. A sunken fontanelle can indicate dehydration. A bulging fontanelle can indicate hydrocephalus or cerebral hemorrhage. A skull midline mass can indicate an encephalocele or a meningocele. Next, we'll move on to the face. With the face, we're looking for a red eye reflex with the light. A white eye reflex indicates retinoblastoma. So red eye would be normal, white eye is abnormal. We're looking for full and equal extraocular eye movements. For the ear, we're looking for a patent ear canal and that the child responds to a loud noise. You're doing a quick screening for hearing there. Epstein pearls are little white cysts that are common on the soft palate. Abnormal findings in the face. If the child had a forceps delivery, facial palsies to the facial nerve may be present. White eye reflex, we said, was retinoblastoma. Abnormal extraocular movements, subconjunctival hemorrhage, if the eye is looking down, that's called sunsetting, can be indicative of hydrocephalus. Epicanthal folds in the eye are indicative of trisomy 21 and fetal alcohol syndrome, as well as low set ears can indicate trisomy 21 and Turner syndrome. For the tongue, you'll look for a shortened frenulum that will affect the child's ability to feed, and a lingual thyroid at the back of the tongue. A hypoplastic philtrum is indicative of fetal alcohol syndrome. Cleft lip or cleft palate may be present. Mandibular displacement from injury during birth. This is especially common if they had a breech or a face presentation during delivery. On the neck, webbing indicates Turner syndrome. If they have limited movement, that may indicate torticollis, which is a shortening of the sternocleidomastoid muscle. Branchial cleft cysts are on the lateral side, and then a thyroglossal duct cyst is on the anterior side. Moving on to the genital assessment. Phimosis. Phimosis is very common in infants. This is when adhesions prevent retraction of the foreskin, and those adhesions will dissolve with age. Checking to make sure the urethral meatus is in the normal location and they don't have hypospadias or epispadias. Hydrocele is very common in preterm infants. That's where the peritoneal fluid will leak into the scrotal sac and it will cause it to be enlarged and full. Checking for bilateral testes. In females, checking for the presence of the labia majora, the clitoris, and those can commonly be enlarged because of the hormone transmission from the mother. A bloody tinged vaginal discharge is also very common with infants. Abnormal genitalia findings, hypospadias or epispadias, non-palpable testes, or an imperforate vaginal opening in a female. The back assessment, if they have good muscle tone, straightened spine, and a patent anus, that would be a normal assessment. Abnormalities, hypotonia, they're kind of floppy. Scoliosis or an S-shaped curvature. Spina bifida or spina bifida occulta can be indicated by a sacrococcygeal nevi, hair tuft, sinus tract, or pinpoint opening, and then anal atresia, where you don't have an opening for the anus. Normal extremity exam. They're moving all of the extremities equally. Their leg lengths are equal. They have 2 palmar creases, and their brachial and femoral pulses are strong and equal. Abnormalities for the finger. Polydactyly or more than 5. Syndactyly, where the fingers are fused together. A single palmar crease, we used to call it a simian crease, but we don't call it that anymore. A single palmar crease is indicative of trisomy 21, trisomy 13, fetal alcohol syndrome, Klinefelter's, and Turner syndrome. Erb's palsy would be an abnormal movement of the arm from a brachial plexus injury during birth. The Ortolani and the Barlow maneuvers, these are maneuvers that we can use to test for developmental hip dysplasia. And as you're manipulating the hip, you'll feel a clunk if there's developmental hip dysplasia as you're dislocating or relocating that joint. Clubfoot can also be present. Now we're going to do an abdominal assessment. Normally, the bowel sounds should start within hours of birth. The liver should be palpable at the right costal margin, and the spleen may or may not be palpable at the left costal margin. The umbilical cord should have 2 arteries and 1 vein. Abnormalities, we may see a scaphoid or scoop-shaped abdomen. That is indicative of a diaphragmatic hernia. An infection at the cord base or a herniation at the cord base are abnormal. Distension of the abdomen can indicate necrotizing enterocolitis or obstruction. And an umbilical cord with 1 artery indicates that they are at higher risk for other abnormalities. Vertebral, anorectal, cardiac, tracheoesophageal, renal, and limbic deformities are higher rates when you have 1 artery present in the umbilical cord. And then finally, we're doing the heart and the chest assessment. We're looking for, no work of breathing. They don't have any intercostal retractions. There's no thrills. There's no murmurs. Their breast engorgement is very normal after birth, and there may actually be something called witch's milk, which is a watery nipple discharge. That's all very normal. Abnormalities in the chest or the heart, intercostal retractions. They're working very hard to breathe. A thrill, a murmur, abnormal heart sounds are all concerning for congenital heart disease. If the heart sounds are on the right side, that indicates dextrocardia, where it's flipped. And then widely spaced nipples indicate Turner syndrome. So this is our detailed assessment that we're doing of that neonate in the hospital. As we're doing their wellness exams as they age, we're doing a lot of these over again at the first week and the first month, but this will cover everything detailed wise that we need to know about that neonate. Next, we're going to move to the newborn reflexes, and these are very commonly tested. So I've grouped them for you. And the way that they're set up is the name of the reflex, the stimulation, the response, and when it extinguishes or goes away. The first one is going to be permanent. It does not extinguish. It's called the blinking or the pupillary response. As you flash the light in the eye of the child, they should blink and their pupils should constrict, and that's throughout life. The first group that we have is 3, and these should be extinguished by about 6 weeks. The glabellar response, this is when you're tapping above the nasal bridge. They should stop blinking after a while when you're doing that. The crawling reflex, you put the child in a prone position on a flat surface, and they will make crawling movements of their extremities. The spinal parege, you're going to hold the baby in a prone position and stroke upwards along the spine. That will cause extremity flexion, head elevation, urination, and a cry. All of these will extinguish about 6 weeks. Next, we have our 3-month group. We have 4 of those. So 3 for the first group, 4 for the second. The rooting reflex is stroking at the corner of the mouth. The child will turn towards that. That encourages feeding. That's at 3 months. Stepping, you hold the child supported on a flat surface and they will make stepping movements with their feet. That disappears at 3 months and it doesn't return again until they start making stepping movements on their own. The sucking reflex, if you put your finger in the mouth, they will start sucking on that. And then the placing reflex sounds similar to the stepping, but you're holding them again. You put the anterior tibia against a hard surface. They will lift the foot, flex the extremity, and it's kind of like they're stepping over whatever that object is. Next, we have 1 at 4 months. That's the Babkin reflex. This one's not very commonly tested. Applying pressure to both palms, the head will flex, rotate, and open the mouth. The biggest group that we have is the 6-month group. The Gallant reflex, you're going to hold the infant prone, and now we're going the other way. We're stroking from C7 to the buttocks. The pelvis will swing to the side that you're stroking. The Moro or the startle reflex, if you have a loud noise or rapid lowering of the baby, they will fling out their arms, flex their thighs, and then return the arms to the body and start crying. That's the Moro reflex. Swimming reflex, we do not test because we don't put babies face down in water, but when we do, we know that they do make coordinated swimming movements. The tonic neck or fencing reflex, the child is in a supine position, you turn the head to 90 degrees, the ipsilateral arm will stretch out and the contralateral arm will flex. It looks like they are fencing. Palmomental, you're going to stroke the thenar eminence proximal to distal, and that will cause an ipsilateral mentalis twitch. Tonic labyrinthy, changing the child from a prone to a supine condition. When they're in that prone condition, their extremities are going to be flexed. When they go to supine, the extremities extend. The palmar grasp, putting your finger in the infant palm, they're going to grasp around that. Those are all of our 6-month extinguishments. Next, we have our 12 months. The plantar grasp is very similar to the palmar grasp, but it's on the bottom of the foot. That disappears at 12 months. The Babinski reflex is when we trace up the side and bring it in. The big toe will dorsiflex and the other toes will fan out. That starts to extinguish at 12 months, but can be present all the way up to 24 months in a normally developing child. Lots of questions on newborn reflexes. Next, we're going to go into the neonatal intensive care unit. I had the best pediatrics professor when I was in PA school, and one of the most important things that she taught us is that everything can be a sign of sepsis. If you don't know where that fever is coming from, you need to find out. So any infant with abnormal vital signs should be transferred to the NICU. These are just a fast kind of listing of the common diseases that end up, where infants end up in the NICU. If they have cyanosis, they get a full sepsis lab panel, chest x-ray, echocardiogram, EKG, and arterial blood gas, trying to determine if it's a pulmonology or a cardiac etiology that's causing that perfusion disorder. Hyaline membrane disease, we'll highlight that one in detail later on in the presentation. This is a common disorder where they don't have enough surfactant in a premature infant, so the alveoli stay collapsed. Ventilation, oxygen, CPAP, PEEP, intubation, and synthetic surfactant are the treatment for that disorder. Meconium aspiration, we mentioned in a post-term infant that they may pass their first meconium while they are in utero. They can aspirate that. That is treated with ventilation, ECMO, surfactant that helps to dissolve the meconium, and nitric oxide, which helps to increase the lung blood flow. Neonatal meningitis. The important part about this is that we all know that nuchal rigidity is associated with meningitis, except in infants. So this is fever with no nuchal rigidity. Lumbar puncture is the diagnostic for that, and an ampicillin and gentamicin combination covers well for group B strep and E. coli. Other group B strep infections like pneumonia or bacteremia, much more common in preterm infants or infants who have had premature rupture of membranes. This will start to present 1 to 7 days post-delivery. And again, you have that combination between ampicillin and gentamicin for good coverage. Remember that we measured glucose as part of the newborn assessment. Hypoglycemia is defined as a glucose less than 40. Hyperglycemia is defined as over 125 in a term infant or over 150 in a preterm infant. These are much more associated with diabetic mothers. A normal glucose at 45 minutes should be about 45 to 125. If the child is at 45 and asymptomatic, you're going to feed the child and recheck every hour. If they're 25 to 45, so getting lower, you're going to give them dextrose gel, feed them, and recheck them more frequently, so every 30 minutes. If it's 25 or less, that means an immediate intervention. That would be an IV glucose with bolus, and then you're checking again every 30 minutes to make sure those numbers are normalizing. I'm also going to mention the torch infections here. Remember that these are the infections that if the pregnant mother gets these, they can affect the developing fetus. These are the common abnormalities that we see in children whose mothers have been affected by a torch infection. T is for toxoplasmosis. That can be transmitted usually during the pregnancy when they're cleaning out a cat litter box. Hydrocephalus, chorioretinitis, and intracranial calcifications are the characteristics for that disorder. O stands for other, and the first of that is going to be varicella. This presents with skin lesions, limb hypoplasia, and neurologic delay. Next, we have syphilis, which is Hutchinson's teeth. They're peg-like incisors. Interstitial keratitis, which is where the blood vessels grow into the cornea, and hearing loss. Parvovirus B19 causes neurological deficits, and hydrops fetalis, which is systemic edema. And then Zika disease is associated with microcephaly. Rubella, that's the R in torch, hearing and vision loss, cataracts, hepatosplenomegaly, neurologic and cardiac deficits, and a blueberry muffin rash, which looks like little tiny blue spots, kind of instead of a red rash, a blue rash. Cytomegalovirus, hearing loss, chorioretinitis, petechiae, jaundice, microcephaly, hepatosplenomegaly, and intracranial calcifications. And then finally, herpes simplex causes blisters, conjunctivitis, hypotonia, hepatitis, DIC, encephalitis, and sepsis. Next, we're going to talk about the vaccine schedule. This is mandated by the CDC. If you work in a pediatrics office, they may have little changes to this, but this is, again, followed by the CDC, and I'm going to show you a couple variations of this as we go through. You'll see that I have this set up from birth to 16 years, and there are some ages that are skipped in there, and those are just times that we're not giving vaccinations. The list of the vaccinations is on the bottom left here. RV is for rotavirus. PCV13 is the pneumococcal conjugate vaccine. HIB is Haemophilus influenza type B. IPV is the inactivated poliovirus. DTaP is diphtheria, tetanus, and acellular pertussis, and you'll also see this as Tdap later on. MMR is measles, mumps, and rubella. HPV is human papillomavirus, and then MCV is the meningococcal conjugate vaccine. The first one that we're going to start with is the Hep B, and I'm going to throw you a little hints as we go, and these are just ways that I remember this. Hep B is birth. That's where we remember that one. We gave that at the newborn assessment. The next one that we have really for the majority of shots is going to be at the 2-month visit. You see this kind of little dotted area at 1 month. That means that hepatitis B can be given anywhere from the 1 month to the 2-month visit for the second shot in that series. But at 2 months, we get 1, 2, 3, 4, 5, 6 vaccines. At 4 months, that looks pretty similar to the 2-month shots, but the only thing that we're missing there is the Hep B. And then at 6 months, it looks very similar to the 2 months. So this cluster that comes together, the way that I remember that is that babies run, play, and hide. So that's B for Hep B, R for rotavirus, P for pneumococcal, HID for Hib, polio, and DTaP. That's how I remember those. And I just remember 4 months is all by itself. It doesn't have the babies part. The other thing I'll point out about this is that Hep B and RV, there are 3. So that all rhymes. Hep B, RV, there are 3. Next down, we have our 12 to 15-month injections are going to be another pneumococcal, another Haemophilus. Now is the first time that we're going to see an MMR and a varicella, and they can be given anytime from 12 to 15 months. We also see the first in our Hep A series. The way that I remember what has 4 doses is that HI, IP, PCV, they all start with the last letter of the prior vaccine. So HI, Haemophilus influenza, IP, polio, and pneumococcal all have 4 doses. So Hep B, RV, there are 3. HI, IP, PCV have 4. Next, we're going to go to the 15 to 18-month visits. That can be the DTaP. That's going to be 4th in that series. And then the second Hep A is going to be given at 18 months. The way that I remember this one is that MMR and VAR go far. They're farther on in life, and they always come together. So then at 4 to 6 years old, we have another series. We have the polio, the DTaP, the MMR, and the varicella. And then we have our final Tdap, which is in that series. That's actually the 6th in that series, is 11 to 12 years old, but that's now a Tdap instead of a DTaP. With that 11 to 12 years, we also have the HPV and the MCV vaccine. And then the final vaccine is MCV. And the way that I remember that one is MCV before you're free to go drive. And 16 years is usually when people start driving. Lots of questions on vaccines. Remember that this is a standardized distribution for these. Some offices may be a little different, but lots of questions on these. So make sure you know these. And I'm going to remind you as we go through the wellness visits on when things are due. The next slide, we're going to talk about motor and speech development. There's lots of different milestones that these kids are meeting, but these are the most highly tested ones. So that's why I want to set these up this way. So for each age, you're going to see the motor and the speech milestone for that age. At 3 months, the first thing they're doing is heads up. They're holding their head up by themselves. Babies are kind of starting to coo softly, really not saying any words or any syllables, just kind of cooing at that age. Then we go to 6 months, and at 6 months, they're sitting up and they're starting to babble, ba, 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 da, 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 kind of syllables. Then we have 9 months, and at 9 months, they're starting to crawl and they're starting to imitate sounds, commonly animal sounds at this age. At 12 months, they're now standing and they say 1 to 5 words. They may not be really understandable, but they've got about 1 to 5 words under their belt. Next, we go to 18 months. At 18 months, they're running. They've got about 5 to 20 words that they've mastered. At 2 years, they're jumping. I remember jump on 2 feet, jumping on 2 feet. And they've got 2-word phrases that they can speak. They have about 100 words in their vocabulary at this time. At age 3, we've got a tricycle and 3-word phrases. So 3 tricycles are motor, 3-word phrases, and they've got about twice the amount of words at 3 years than they did at 2 years. So instead of 100, now we're at 200. Then we make this huge jump in vocabulary to 4 years. We now go to 1,000 4-word sentences, and they're hopping on 1 foot. So these are the most tested of these. We're going to go through them in detail as we go through all of our well child visits, but if you can memorize these, you're probably good to go for the boards. Now we're going to do all of our wellness child visits. You're going to see that I've set these up for a history exam, what the daily routine is, what are their milestones, what are their vaccinations, and what guidance should we be offering to these. So this is from the perspective of the provider of what they should be doing for the child at this visit. I mentioned that this first week exam, we're going to be repeating almost all of that assessment that we did at the hospital just to make sure that we double checked that. You're also going to see that a lot of these questions are similar throughout these wellness child visits. So anything that's a new thing we're talking about will be in bold. Starting with the history on our newborn, our first week, asking, was there any pregnancy complications? Was it a cesarean or a vaginal birth? Was there any birth trauma? What was their Apgar, and did they have jaundice in the first 24 hours? Asking the parents, are you planning on breastfeeding or formula feeding? Are there any hearing or vision concerns from that quick screen that you had at the hospital? This is a really important safety point. Teaching the parents about not co-sleeping, because that is a common cause of childhood injury in the newborn phase. The parents are so tired and they roll over on the baby. So our rules for safe sleep are sleeping alone, on the back, in an empty crib with a tight sheet and nothing else in it. Are they in a rear-facing car seat that is manufacturer's guidelines set up to be safe for them? Have they had have they gone to a fire station, had that checked, or do they know that it is appropriately installed? Screening for postpartum depression for the mother, especially if you're concerned to the point that she might have postpartum depression with psychosis. Does she have a good family and friend support system? Can she afford the baby items, or does she need help with that? Next, we're going to go to the exam. These are all normal findings or things that we should be screening for. You may notice that the child responds to the voice by opening eyes, looking for that red eye reflex and the equal extraocular movements. All the jaundice should be resolved by about 2 weeks, and the milia on the face should resolve by about 4 weeks, but that's common at that newborn visit. Erythema toxicum is still going to be present up to 2 weeks. Listening for any heart murmur, looking for that neck range of motion for the torticollis. The clavicle is the most commonly fractured bone during birth because that's getting that large area out that commonly fractures. So you would feel along the clavicles to make sure that they don't have a broken clavicle. Looking at that umbilical cord stump to make sure there's no infection. Doing the hip maneuvers again to look for that developmental hip dysplasia, the Ortolani and the Barlow. Doing a genitalia assessment, the testes, looking at the circumcision site, making sure that there is a perforate vaginal opening, and then looking at the spine alignment. So a good, thorough exam for that newborn exam. Next, we have our daily routine here. Newborns should have about 1 to 2 ounces of breast milk or formula per feeding every 2 to 3 hours. They should have about 6 to 8 wet diapers per day, and that's going to be kind of a seedy, yellow, mustardy kind of stool. At nighttime, they should be sleeping about 6 to 7 hours, 14 to 16 hours total, and then waking to feed every few hours. For their milestones, not a whole lot here. Their eyes follow past the midline. Their fists should be unclenched. They should be able to look and focus at close objects, and they may turn their head towards sounds, like the sound of the provider talking to the parents. Their reflexes, we just went through a whole slide on that. These are the most commonly tested ones in the clinic. So obviously we're not going to do the swimming one, but the blink, the Babinski, startle, gallant, palmar plantar grasp, rooting, stepping, sucking, and tonic neck, those are all easy to do in the clinic that are safe for the child. For the vaccines or tests, that hepatitis B, if we did not get that in the hospital, we're going to dose it at this first visit. We're also going to go over those newborn heel prick results to tell them if there was any of those metabolic disorders. Another test we'll do is the hearing test. We did a screening test in the hospital, but we're going to do it here as well. And that's, do they respond to a loud sound? And then finally, the guidance that we're going to give to the parents. Vitamin D deficiency is very common in infants. So supplementing 400 IUs of vitamin D3 every day. Talking to the parents about tracking how much this infant is eating, sleeping, and their diapers. There's so many free apps that you can get for your phone that are easy to do. And that way you can make sure that the child is getting the nutrition that they need. Talking to them about safety, monitoring their pets. Children are they're commonly attacked by pets, usually as they get older when they're kind of messing with the pet, but the pet is new to this baby. They may feel protective or aggressive against this baby because it's taking away their parents. Making sure that nobody's smoking around the infant. Everybody who holds the infant is washing their hands, not kissing the baby on the face to transmit things like influenza. Do not shake the infant. Make sure the infant's head is always supported, and then making sure that all of the caregivers are CPR certified. Social is really important to address as early on as you can. Establishing routines so that it's good for the caregiver and the child. Going outside and walking, getting out of the house, reading to the child. That's great for intellectual development. For bathing, no more than 3 times a week because it can dry that infant skin very easily. You want to make sure that you're using a hypoallergenic soap and using a moderate temperature that you always check before you put the infant in. Diaper rash is very common. The ways that we can avoid that is by changing that diaper frequently. And if it looks like they're getting a rash, using a barrier cream. If they had a circumcision, discussing circumcision care, cleaning it with warm water, changing that bandage out, monitoring for any signs of infection, and using Vaseline on the skin as it heals. Umbilical cord care, letting the parents know to keep that umbilical cord clean and dry, and it will naturally fall off within 1 to 3 weeks. So that newborn visit is very comprehensive. Next, we're going to go to the 1-month-old wellness visit. If you look at that history, that's pretty much the same. Rashes, fevers, illness, accidents, anything I need to know about. Are they safely sleeping? Are they using their car seat? Are you still having that postpartum depression? Any concerns there? But the new question is, are we doing okay with family adjustments? You've now had a month to kind of get into this. Are the siblings adjusting? Are the parents getting along okay? Are the pets adjusting? And just making sure that it's a happy environment for the infant. For the physical exam, we're going to notice that that posterior fontanelle is starting to close. That broken clavicle, if they have that, is healing. The umbilical cord stump should be healed at this point. Doing that genitalia exam, if they didn't have both testes present at the last visit, checking again, and making sure that that circumcision is healed. For the daily routine, no changes there. Pretty much the same thing as the newborn was doing, making sure they're getting plenty of food, they're having plenty of wet diapers, and they're sleeping well. They may show you the app that they've been using to track all that progress. Milestones, no difference there either. You know, they're just kind of following voices, their eyes are moving, the same reflexes that we had at the last visit. Nothing should be extinguishing yet. For the vaccine, that vaccine dose, the second dose can be given at 1 or 2 months. Typically, they do it at 2 months. And then our guidance, nothing much changing there, except for cradle cap is starting to develop at this time. Olive oil compresses are the safest treatment for this. There's no side effects to that. The parents just don't like the way it looks. They can be bothered by that, but let them know that it's a very benign condition. Thrush is also starting to develop at this age. This is much more common in formula-fed infants. It's a whitish coating on the tongue that can be scraped off, and that can be treated with an oral nystatin. Next, we have the 2 months old. And for this one, the only thing new in our history is asking about colic or recurrent vomiting. We're thinking about things like pyloric stenosis at that age. For the exam, their weight, they should be gaining about 1 ounce per day. And the height, we're going to be about 1 inch per month gain, kind of come from this point here. We should notice that that posterior fontanelle is now closed, and any broken clavicles that they have are now healed. For our dailies, we're going to be going 4 to 6 ounces per feeding every 3 to 4 hours. So we're increasing the amount of food that they're getting. And that stool is going to change from the seedy mustard yellow to a thicker brown stool. Same amount of sleep. Our milestones, we do have a few new ones here. They're starting to hold their head up during tummy time. They're turning their head towards familiar voices like their parents or caregivers. They're starting to coo. Remember, we see that at 3 months, and they're starting to smile. And that is the most awesome thing as a parent, to give all of your time and energy and effort to this little infant, and finally to see them smile at you makes you feel like it's all worthwhile. So that's a really cool thing. For our vaccine, remember, this is the first in our kind of chunk of that. Remember my mnemonic: babies run, play, and hide. So that's BRPHPD. For our guidance, the only thing new on this one is that these babies are starting to get kind of squirmy. As newborns, they didn't move much. So now they're kind of starting to squirm. And so making sure that they are strapped in while they're on the changing table and the swing so that they don't fall out. Also making sure that there's no bottle in the crib. Number one, it's a safety hazard, but number two, that will lead to bad habits and tooth decay later on in life. Next, we have our 4-month-old visit. The only thing new in the history here, we're starting to think about jar foods and fortified cereal. So asking the parents, have you started this? 4 to 6 months is average for this. Have you noticed or have any concern about food allergies? Because we're going to be starting to go through the process of trying new foods. Is there anything that they have that is concerning? We're also going to do a lead screening. Any homes that were built prior to 1978, we should be asking them, do they have lead in the paint, or have they had lead remediation in the house? Also starting to think about long-term childcare plans. Usually about month 3 or 4, the maternity leave is ending. And so trying to get the parents to think about what is the next step in the care for this child. For the exam, they're starting to be really interactive with that pediatrician, and they're giving you facial expressions and movements. They're also starting to drool and chew on things. We're getting prepared for that teething phase, because at 6 months, that's when we start seeing those teeth emerge. For our daily routines, we're maybe starting the jar foods at this point, the fortified iron cereals. If the child is acting hungry, they're just maybe not getting enough nutrients from the breast milk or the bottle feeding, we may be adding that to their diet. Now we're going to 9 to 10 hours at night, and we're going to a 2 daytime nap schedule, still 14 to 16 hours total for sleep. Tons of milestones here for 4 months old. The child is really starting to get fun and interactive. They're holding their head up unsupported. They're able to sit straight if they're propped up against something. They're raising up their head and supporting themselves while they're on tummy time. They're starting to bring things to their mouth, roll from front to back, grabbing, reaching, holding toys, and then they're supporting their body. If you're holding them up, they're able to support their body on a surface. For social, this is where they're fun. They're making eye contact, they're cooing, they're laughing, they're showing memory of the parents. They show memory of their favorite toys. They fuss to get attention from their parents, and they know who their parent is. The things that are starting to extinguish: rooting, stepping, sucking, placing. Remember, that was about 6 weeks that extinguished. So between the last visit and this visit here. Our vaccines and tests, this is that second chunk of the babies run, play, and hide, but we don't have the Hep B on this one. So this is just run, play, hide for this one. For our guidance, not only are we going to be supplementing the vitamin D, but we worry about iron deficiency anemia at this time, because their iron stores are going to be getting lower and lower. Iron of 1 mg per kg if they're getting more than 50% of their food from breast milk. Baby proofing the home. They're starting to get more mobile. So toilets, strapping furniture in so they can't pull that over on them, plugging up outlets, making sure that you're getting a stair gate. We're going to be getting into the teething process here. So getting some refrigerated cold rings, not frozen, but refrigerated. Avoiding any of the pain gels, because they can aspirate that. You can start to massage the gums with a little finger toothbrush. That can help with some of the pain. And as we start the foods, we're going to do one new jar food per week. Always ask them to try to start with the vegetables, because once the kid has sweets, they're not going to want to go back to vegetables. So starting to do one new vegetable per week. And the reason we only do one per week is we're looking out for any allergies that we can easily identify as soon as the child has them. For our drinks, we're still only doing breast milk or formula, no juices, no sugary beverages. Next, at 6 months, the only new history question here is going to be, have you lowered the crib mattress? Is the child tall enough, or are they starting to climb out that you've lowered that down for safety? For our exam, the rule of thumb for weight is going to be twice the birth weight at 6 months and about 2 centimeters of growth per month. Again, you're examining those testes, making sure that those have both dropped in males. And this is where our teeth are starting to come in. So we were preparing for that teething phase. The lower incisors are emerging. There's going to be 2 of those. That's a common board question. When do the first teeth come in and what are they? 6 months, lower incisors. We have a little change in our daily routine here. We've got 8 ounce per feeding every 4 to 5 hours, so getting lots more nutrients there. We've got jar food, solid food, and we're adding that one new food per week. And then for our sleep, same thing, diapers, same thing, but we've lowered that crib mattress for the safety of the child. Our milestones, we're now sitting unsupported. We've got a raking grasp, which is a more primitive grasp. We're bringing food up to our mouths, rolling both front to back and back to front, and starting to scoot. In social, they're developing stranger anxiety. They only want to be with their parents. They're starting to manipulate objects and toys. They're imitating especially animal sounds, and they're interactive with their pets, their family, their toys. For their language, they're starting to learn what the meaning of the word no is. And we don't want to scare them with the word no by yelling at them, but we want to get their attention with that. They're learning small words like mama and dada. And this is where they start their self-identification. If you give them a mirror, they can identify that that is themselves. The extinguishing reflex, remember there was that whole group of those at 6 months, the startle, the gallant, the tonic neck, and the palmar grasp. Those are going to be the ones that we're going to be testing in the clinic. Our vaccine, remember that was our matches are 2 months. So babies run, play, and hide. Plus we have an influenza that starts yearly at the age of 6 months. For guidance, we're now going to change their bathing to every 1 to 2 days. Their skin is able to tolerate more of that. We're still using the hypoallergenic soap and the tepid water. As they're starting to eat, we're worrying about the choking hazards, making sure that everything is pulled up off the floor so that there's no small toys or objects on the floor that they could choke on, making sure that their food is cut into very small bites, and making sure that we're avoiding honey, and because that is a common cause of botulism prior to the age of 1. 9 months old, for 9 months old, we are looking at the history. The only thing that has changed here is we're looking at what is their appetite, what are their favorite foods, are they having any sibling issues, are there any concerns with the daycare or safety, or are we looking at nannies or au pairs? How is the childcare situation working out? And then are they scheduled for a dentist visit? They don't have to go to the dentist quite yet. That's usually about a year that we have that, but the dentist is something that you should at least be getting established with at that point. For the exam, we're gaining 1 pound per month and about 1.5 centimeters per month. For our teeth, we've got the upper and lower central incisors. So we've got 4 teeth total. This is also the age where we should be starting our autism screening. If the child is not making any eye contact, they're not responding to their name, they don't have any expressions like smiling or laughing, that is concerning. Our anterior fontanelle also starts closing about 9 to 18 months is going to be when that's completed. For our daily routine, we're now into the habit of having about 3 meals, 2 snacks, and we're encouraging a lot of varieties of foods, again, trying to get those vegetables in there. For our wet diapers, we should be having about 4 to 7 times a day. So they're urinating less, but they're doing it in larger quantities. And that's getting them ready kind of for the potty training years. And that should be a thicker brown stool. Our milestones, we've graduated from that raking grasp to the pincher grasp, which is a more advanced grasp. They're crawling, they're pulling themselves up to stand, they're waving, throwing, and banging objects together. They love to bang those pots and pans. For their language, remember at 9 months, we're starting to babble, and that's going to be ba, 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 ma, ma, ma. You're going to be making those syllable words. They're also able to respond and understand simple commands. For the reflex, there's a new reflex that appears at 9 months that will stay persistent throughout the lifetime. It's called the parachute reflex. And as the child falls, it's protective for them. They will fling their arms out to protect their face as they're falling. And that's something, again, that remains throughout the lifetime. At 9 months old, we have the hepatitis B, the polio, the influenza, and we're also going to be doing an anemia screen here. So we're looking at hemoglobin and hematocrit, and that can be done anywhere from 9 to 12 months. For our guidance, we're going to be focusing on child safety because these children are getting more and more mobile, and the things that you think wouldn't hurt them could put them in danger. Anybody that has a pool should have a pool gate because of the high risk for drowning. Stoves are common for burns, or they pull over hot liquid on themselves, making sure that stairs are gated because they're starting to climb. This is the time when pet attacks are most common because the child is being rough on the pet. They're not trying to hurt them, but they may grab their tail or their ear, and the dog or the cat thinks it's being hurt. So it will lash out, it will bite. Baby proofing. We started talking about that already, but just making sure that everything is secured in the house that could potentially hurt them, making sure guns are put away, any kind of chemicals or cleaning supplies are put up. For our social, we really want to be focusing on getting out and getting them socially ready to start interacting with their peers. Play dates, zoos, parks, you're learning about animals and animal sounds. For the teeth, you're going to start with that finger toothbrush 2 times a day, and you're going to make sure that you're getting established with a dentist. For 1 year, the only thing we're adding to this one is if there's any kind of concern about the vision, you want to go ahead and get established with an ophthalmologist. So strabismus or any kind of family history of any kind of sight disorders, get them established with an ophthalmologist. Couple things here for the exam. They should be 3 times their birth weight at 1 year. They should be 1.5 times their birth length at 1 year. We're going to start our screenings: vision, hearing, autism. What we're looking for on this one, do they have hand preference prior to the age of 2? When they get their shots, they don't cry. That's concerning. It's not that they're being a really good baby or they're not crying. It's that there is concern that they don't respond to pain, which is a characteristic associated with autism. They don't have gestures. They don't interact with the examiner. In a normal child, they should be playful, interactive, crying when they get their shots. For our teeth update on this one, we should have all upper and lower, all of both the central and the lateral incisors, so we have a total of 8. For our daily routine, we're now at 16 to 24 ounces of milk. We've got 4 to 5 wet diapers. Now we're really having those solid bowel movements, 1 to 2 per day, and they're starting to get more and more predictable when that schedule is. For our sleep, 8 to 10 hours at night, 11 to 14 hours total. We're getting less sleep than we did when we were an infant. And that's broken up into usually 2 daytime naps or getting to close to 1 daytime nap. For our milestones, they're feeding themselves, they're walking, they're pulling up to a stand, waving, throwing, banging objects, turning pages in books. They're using sippy cups. They're helping the parent to dress them. They're really starting to imitate animal sounds, and that's a fun kind of game to play with them, especially if you're at the zoo. What sound does a zebra make? I don't really know. What sound does a lion make? Pointing to objects when they want something. At this point, they understand the meaning of the word no. They also have about 1 to 5 words under their belt. They may not be perfect, but the parents can at least understand them. Our extinguishing reflex, the Babinski, remember, is going to start to extinguish around 12 months, and that plantar grasp is also gone. For our vaccine, lots of stuff that we could potentially get at 12 months old. And remember, these are ranges that they offer. So the 3rd Hep B, the 3rd polio could be offered 6 to 18 months. The pneumococcal and the Haemophilus, the 4th dose, 12 to 15 months. The measles, mumps, and rubella and varicella, that's usually given at this visit. The range is 12 to 15, but usually that's when this is given. Hep A, first dose can be anywhere from 12 months to 23 months. We also want to do a lead screening at this visit, and then our influenza, if we haven't gotten that yet. We know that that is yearly, starting at age of 6 months, forever and ever. For our guidance, we're going to start supplementing vitamin D whole milk. So we can get rid of the vitamin D supplement if we're going to start that vitamin D whole milk. For sunscreen, that skin burns very easily in an infant or a child, so we want to make sure we're using SPF 50 or 100. Tantrums, behavior is going to start to get difficult right at 1 year. So learning how to parent without yelling or hitting the child is the most effective form, using positive reinforcement and, really enforcing that great behavior. Work on the concept of time out. So have a chair where they can go sit and they know they can't get up until the timer goes off. Obviously at 12 months old, timeout is a little difficult. It's important that the American Academy of Pediatrics recommends no TV or electronics until age 2 to help with development. At 15 months, the only thing we're really looking for that's new in the history here is behaviors. Are they having tantrums? That's normal. Are they biting? Are they hitting? That's problematic. Are they getting along with their peers and their siblings? For their exam, the only thing new about this one is that their first molars, there's 4 of those that are really kind of starting to come in or about in at that point. Nothing changes for our daily routine from 12 months old. Our milestones, the new one at 15 months is stacking blocks. The separation anxiety really starts about 15 months old. They don't like to be taken away from their parent. Clapping, imitating their peers, and showing affection to their parents. And that's, again, an awesome part about being a parent is have your kid really kind of snuggle on you. For language, knowing the word no and yes and about 10 words. Again, they may not be perfect, but they can at least have 10 words that they say. Our vaccines, a lot of those, again, are those ranges for the Hep B, the DTaP, the polio, pneumococcal. These are all in that 12 to 15 months range. And then our guidance, nothing really new for this 15-month visit that we didn't have at the 12-month visit. At the 18-month visit, are they ready to potty train? They should be kind of getting to that point where their bowels are predictable, their urination is predictable. Are they able to stay dry for 2 hours, and do they have predictable bowel movements? Those are kind of the criteria to determine if the child is ready to start potty training. Another thing that commonly starts happening at 18 months is sleeping or night terrors. For our exam, our canines are coming in. There's 4 of those. And by 18 months, that anterior fontanelle should be closed. At 18 months, we should be working on a pull-up training pants, so starting to come out of those diapers. And if the child says, hey, I need to go potty, go sit them on the potty and get a training potty for them. For our sleep, we're at about 8 to 10 hours a night, and we're down to 1 daytime nap. And usually it's a longer nap at first, but it can kind of whittle down. For our milestones, we're actively climbing the stairs. We can now use a spoon, maybe not great, but we can use it. They are able to undress themselves and they're scribbling. They're starting to kind of use that fine motor movement with a big fat crayon to kind of scribble and draw. For language, we've mastered about 5 to 20 words at this point. Nothing new for social at 18 months. For our vaccines, we've got that 3rd dose of the Hep B if we haven't already gotten it. Our DTaP, our polio, hepatitis A, and then our influenza, that's just our yearly one. For guidance, socially, we want to get them really kind of involved with their peers, signing them up for some kind of music class or gymnastics class or swim class. Swim class is great because it also helps with safety, but getting them to kind of start interacting with their peers. We can now go to bathing daily using a nice barrier moisturizing cream. They will have a child toothbrush. You can use a training kind of toothpaste that doesn't have fluoride, so just a little pea-sized pebble of that toothpaste. We're avoiding sugary beverages, as tempting as it may be. Sugary beverages and snacks, we want to be avoiding those. And we're going to tell the parents, start going ahead to shop for the low toddler beds or the toddler protective rails, because that crib is going to no longer be safe. A lot of the crib beds can be converted into toddler beds. We've made it to 2 years or 24 months old. So our questions for this one is, have we switched to a toddler bed, or are we at least thinking about it? Do they hit the manufacturer's requirements for safety for a front-facing car seat? There are safety requirements for both height and weight for the child. How's the potty training progress going? Are they making a lot of progress? Are they already trained, or are they not doing very well with that? And you can offer some tips and tricks. For our exam, for our height, we're going to be half our adult height at age 2. We're looking for handedness at this age. Do they have a hand preference for right or left? And at age 2, that's normal. Prior to age 2, that's concerning for autism. Our autism screen at age 2, we're looking for emotional reciprocity. They're not smiling when you're not smiling. They're not responding to anything you're trying to do to interact with them. They don't have any shared play with any of the objects or toys in your office. This is also the first time we're going to screen for muscular dystrophy, and we're looking for the very typical waddling gait. If there's any family history of that, that's when we're going to start to notice that is at age 2. The second molars start coming in at age 2. For our daily routine, now we're going to be switching out of those diapers to potty training. So the child should have at least 4 to 8 times a day where they're producing light yellow urine. They're changing from that night, they're going into the nighttime diaper only and the daytime training pants. The daytime diaper should be done at this point. Switching to that toddler bed, if it's safe for them to do so, is going to be the safest one at this age. We've already talked about that. Our milestones. We're climbing those stairs, we're kicking balls, using cup, spoon, and fork now. So they're using all of their utensils. They're helping to get dressed and undressed. They're scribbling, they're turning doorknobs, which is especially concerning. Make sure that they have that safety lock on there. They respond really well to positive reinforcement at this age. And a reminder on positive reinforcement, if they do something nicely, so let's say they help themselves get dressed, what a great job. Let's go for a walk in the park. So trying to find things that they enjoy so that you can positively reinforce them. For our language, we know no, yes, timeout, and our names. 20 to 100 words are an average for 24 months. 2 to 3 word phrases, 2-step commands. So there's twos there. So 20, 2-word phrases, 2, and a 2-step command. They're able to communicate their needs to their parents. I want this, or I want that, or I want to play. They have understandable speech that's not just to their parents, but other people can easily understand them. And they love to read picture books at that age. And you can talk to them about what do they see in that picture. The important question about our Babinski reflex should be extinguished in all normally developing children at 24 months old. It started at 12 months, but it can go up to 24 months. Nothing really for our vaccine here other than a flu shot. For our guidance, they're getting more active outside. So the importance of bike helmets, eating with their family at the table, establishing that mealtime routine that's going to come in really nicely as they're a teenager and they don't feel like talking to anybody, but they're in that routine. Now they can have TV or electronics, but you want to limit that to 1 hour or less and really be monitoring the content because at that age, they're sponges. So anything that might be violent or scary, they will pick that up. At age 24 months old, they may start to explore their genitals. And we're going to set that up for the next year for 3 years on when that's appropriate to do. 3 years old. At 3 years old, we're asking them, are they in that front-facing car seat? Are they potty trained? Are you having issues with bedwetting? Kids are commonly constipated at that age too, because they don't drink enough because they're on the go. They don't want to miss out on anything. And so constipation is very common in those toddler years. Have you started thinking about preschool? What's going to be the next step in order to prepare this child for kindergarten to make sure that they are ready to go? Is it a next step program? Is it a pre-K program? Is it preschool? Is it daycare? What's the plan? For their height, they're going to be growing about 5 centimeters a year until puberty and about 5 pounds a year until puberty from 3 years on. Those second molars are now in. We've got 4 of those. For our daily routines, this is a good rule of thumb, 8 ounces per water per years old, and that's going to carry us the rest of the way through childhood, making sure that they have well-balanced meals with lots of vegetables, lean meats, low in sugar, low in fat. At 3 years old, they should be having 1 bowel movement a day. If they're having less than that, that is concerning for constipation. At age 3, they should be in a night pull-up, and in the daytime, they should be in an underwear at this point. And that night pull-up, maybe even underwear too, but kind of getting to the point where that night pull-up is going away. For our milestones, they're feeding themselves, they're dressing and undressing themselves, they're drawing a circle, so they're getting better fine muscle movement. Remember 3 for tricycle, that was our mnemonic for that one. They also have 3-word phrases and 3-step commands they can follow. They can also count to 3, lots of 3s in the 3 years old. For our social aspect, they are developing imaginary play. They're afraid of things. There's a monster under my bed. Cooperative play and share with their peers, their sibling, their parents. They're starting to imitate their parents. They love to do chores. So you can give them a little tiny chore, give them a little tiny broom and let them kind of, sweep up after you. We know our name, our age, our sex, 200 to 500 words in the average vocabulary. We're asking questions, we're answering questions, we're developing that conversational skill. Our vaccine, just an influenza. And then our guidance, they're starting to become more independent. So talking about stranger danger, what do you do if somebody approaches you? You scream and you run away, or you yell, "You're not my mother." Look both ways before you cross the street. Kids just dart out into the street, and this is a common time where they get hit. They're newly mobile and they don't have any rules at all. Playground rules, talking about keeping your hands off other children, not hitting, and sharing your turn on the slide and waiting your turn for the swing. As they're starting to explore those genitals, we mentioned that at 2 years old, teaching them that it's only appropriate to do that when you're in your house, and only your doctor or your parent should ever touch you there. You're setting them up to be able to have a conversation with them about sexual abuse later on in life. Age 4. They're starting to get into those school age years. So focusing on any behavioral issues before they become a problem. Do they hit? Do they bully? Do they have good relationships with their peers and their siblings? And if not, how do we intervene before they start school? Do the parents or the child have any concerns about starting school? It's normal to feel nervous about that. We're changing our routine. If you've been a stay-at-home parent, that may be hard to let the child go. Exercise is also very important. We know that obesity is an epidemic for children in the United States. Making sure that they're getting plenty of time of play outside where they're not just sitting in front of a TV and watching movies and playing video games. For their height, their average height is 40 inches and their average weight is 40 pounds. So those are our 4 Our screening for autism at this age, if they become hyperactive, if they're impulsive, if they have outbursts, we may have thought that that was a tantrum early on, but that has been a persistent behavior. They do not like any changes to their routines. All of these are concerning. And it's not just that we're, concerned about autism at 4 years old. We've been kind of seeing these signs, and that's why these well child checks are so important, so that we can catch this early on and intervene and get them the help that they need. At age 4, we have a full 20 set of teeth. For our daily routine, we should be fully potty trained at this point. We may still have some rare accidents. That's very common, but mostly potty trained. At 4 years old, they may give up that daytime nap. Some kids are really active and they will go to bed earlier if they skip that nap. Some kids really like their naps, and it all just kind of depends on the kid. For our milestones, we can play sports, kicking, coordinating, throwing ball. They skip, they can draw a nice picture that is actually understandable of what they're doing. They may start bikes with training wheels. They can hop. Remember, that was our milestone for that one. They can hop on one foot. At 4 years old, they fiercely want to be independent, but they know that they can't. So they will ask for help for a lot of things, but you want to encourage and foster that independence. Their language, they know time and place now at age 4. They don't necessarily know exactly, but they understand what a minute is, what an hour is, what a week is, what a month is, what a year is. And a lot of times they're asking, when's the next Christmas? When's the next birthday? When's the next holiday? So that's how they're kind of marking that. They know about 1,000 to 2,000 words. So we had this huge explosion in vocabulary. 4-word sentences, 4 sentences to tell a story. So there's our 4s. 40 inches, 40 pounds, 4-word sentences, 4 sentences to tell a story. They can count to 10 at this age. They can group and they can sort objects based on characteristics like large or small or red or green or blue. They understand how and why questions, and they will ask a lot of why questions, and they're learning about their environment. Singing, dancing, playing, kind of reading small sight words. Sight words are 2-letter words like is, of, as. They can look at that and they can recognize that. Our vaccines at 4 years old, we got our 5th dose of the DTaP, we got our 4th dose of polio, our 2nd doses of our MMR and rubella, or our MMR and varicella. Remember, those two go together, and then our yearly influenza. Talking about, again, what is a private part? Nobody should be touching you there except for your parents and your doctor. Socially, table manners. They're getting to the age now where you shouldn't be eating with your fingers. So working on that fork, that cup, that spoon. Bedtime routines are really important to establish, both for them and the parent. We're going to get our clothes off. We're going to get into our pajamas. Here's your nighttime kiss. Here's your little glass of water. Go potty. Here's your book. And then they're out. And that's really important for giving good habits later on in life. For discipline, you want to give them some responsibilities. We let my daughter feed the fish. Obviously, we monitored her, but that was her first responsibility. And she loved doing that. That was very important for her. Positive and negative reinforcement. This is not punishment. Positive reinforcement, you give them something good that they want. It does not have to be food or money, could be attention. Negative reinforcement, you take away something they don't like. So if they don't like broccoli, you could say, oh, well, you did such a great job on X today, you don't have to have broccoli. And that would be a good negative reinforcement. Again, keeping your cool as a parent can be tough, but no yelling, no hitting, focus on that timeout as the punishment. 5 years old, switching them to a booster seat if it's appropriate, if they meet the height and the weight requirements for the safety requirements. Are they adjusting well to kindergarten? Are they making friends? Are they loving learning? Are they loving their teachers? Or are they constantly getting in trouble? Talking to their teachers about their attentiveness. 5-year-olds can't really sustain their attention much, but are they able to complete a task? What are their grades or their reviews? Are they getting mostly good or are they getting mostly bad, and how to address that? 5 centimeters gain of height a year from 5 years old till puberty, and 5 pounds gain a year till puberty. Not much new for screening for that. For our daily routines, usually you're down to 1 snack at that point. They may have 2 small snacks, but usually it's just 1 little snack. Another key thing is to not let them over snack, because if they over snack, then they won't eat their meals. By 5 years old, that nap is usually gone. Especially when they start school, they just get a brain break. They don't even get a nap anymore. For our milestones, they're doing great with their sports, their coordinated movements. They can now balance with their eyes closed. That's a new milestone. Using child safety scissors and developing that fine motor movement. Starting on a bike with training wheels if they haven't already done that. They brush their teeth unassisted, and they love to dance. For social, they're doing small chores now unassisted. They're feeding that fish, or they're sweeping up one area, or they're cleaning their room. At 5 years old, they really start to show empathy. They understand feelings. They say, oh, that person looks sad. Did I do something? And they understand apologizing and saying you're sorry. But this is really good time for emotional development for them. Our vocab, 2,200 to 2,500 words. For 5, we're saying 5-sentence words. We're telling stories. We can count to 20. We're asking and answering all and every type of question in the entire world. We've got at least 20 sight words under our belt. We understand the use of pronouns, verbs, and nouns. Vaccine is just a yearly flu shot. And the only thing that we're monitoring again at 5 years old is just saying, hey, we were already doing this, but the TV and electronics and all that stuff should be 2 hours or less. And again, really monitoring that content for things that may be disturbing to them. 6 to 12 years old, these are all kind of the same, kind of those pre-teen years, working through those. These are going to be annual visits. At age 12, you can stop the booster car seat as long as they meet the height and weight requirements. Focusing on making sure they have good behavior. Are they inattentive? Are they angry? Do they bully other people? Do they have good relationships with their peers and their siblings? Do they backtalk? Do they sass? Is there any concern for things like oppositional defiant disorder or conduct disorder? How's their school going? Are their grades, are they doing well? Are their teachers really pleased with them? Are there other areas like math or reading or writing that they may need to get a tutor in? Self-image is also starting to develop at this age. Do I weigh too much? Do I look good? Do I fit in with other people? And this is a really important time for the formulation of their self-confidence. So making sure that they know they are loved, they are pretty, they are important, they are who they are and what their strengths are. That's a really important role as a parent at this age. For our exam, the most important thing here is maintaining a healthy BMI and making sure that they're not getting into that overweight category. Our baby teeth will fall out from ages 6 to 12 at different times, and the new teeth, the adult teeth, will grow in. Our Tanner stages of development, we should be documenting at each exam to see if we're seeing the presence of the secondary 6 characteristics. For daily, may or may not need snacks at this point. Bedtime should be by 8 to ensure that they're getting plenty of sleep for school. Maybe it's not that they're a bad kid. Maybe they're just overly tired when they go to school. For our milestones, we're riding bikes without training wheels. We're really active in classes like karate and dance and chorus and band. For their friends, they have a good social circle. They understand what is right and what is wrong. They start to develop little crushes, kind of romantic feelings. They are understanding their family role. What are my chores? What are my roles? What are my responsibilities? They start to discuss events with their family. This is what I did at school today. This is what I'm learning. This is what I'm excited about in life. For physical, we're going to start seeing those changes for puberty. Onset is usually age 10 to 12. Talking to them about menses, their voice and body changes that will start happening, breast development, body hair, and acne. This is a very anxiety-inducing time for kids, so kind of telling them what to expect is going to prepare them to go through that. Our vaccines, our final dose of our DTaP series is given as the Tdap, ages 11 to 12. Our first dose of the meningococcal is at ages 11 through 12. Gardasil can either be given 6 months apart, 2 doses, ages 9 to 14, or in a 3-dose series, ages 15 to 18, and then our yearly influenza shots. For our guidance, kind of getting more into grown-up type issues. Are you being bullied or are you being a bully? Do you wear your seatbelt at all times? Making sure that if there's any concerns about safety at your friends' homes, like they leave guns unlocked. Stranger danger. How do you find somebody that can help you? Look for somebody who's police or a firefighter or another mom that has a kid. That would be a safe place to go. Telling your parent if you've been hurt or touched inappropriately, making sure that you have that open avenue to discuss abuse. Making sure that all of their homework is done before there's any electronic activities, and making sure that they've completed that and that they're diligent about turning it in. For discipline, having firm rules and carrying out punishments. If children know that their parents won't carry out the punishment, then they'll do whatever they want. So establishing those rules to say, this is the way that things will be done is good for them. Starting to talk about smoking, drinking, and drugs. At this age, they're really not doing a whole lot of that, but they may be starting to get exposed to older children who are doing that. For sex, the average age for intercourse at the first time is 15. Kind of starting to talk about STDs and pregnancy, but you may not need to go too much into it at that age. Kind of see what they're comfortable with as a parent to a child. Then we have our teenage visits. Teenagers are very scary, 13 to 18 years old. So things that we're looking for here, all of those things are important about the behavior and the self-image and the exercise and the diet, making sure that all of those are optimized. But we're looking for what are their future developments and interests. You want to see what are they going to become as an adult? Do they have a part-time job? Obviously, if it's age appropriate. Are they driving? Are they sexually active? Are they smoking, or have they tried drugs or drinking? These are things that you may want to ask the parent to step out of the room for, so that the child will be honest with you. Academic interests and career goals, getting to know who they are as a person and what their interests are. For their exam, adult height for girls is age 14 to 15. And then for boys, they'll have that extra growth spurt, and that's 16 to 17 years old. Then the huge growth spurt from preteen to teen is ages 12 through 15. We will have all of our adult teeth, 28 of them, by age 14. For daily, the only thing that changes about this is you can push that bedtime back to 9 o'clock. For milestones, teenagers are moody, but making sure that they're not suicidal, making sure that they know that they can talk to their parents, making sure that they're in healthy social circles with kids that are of good academic interest, good families that are safe. Dating, what are the rules for that? What are the rules for social media? Social media can be devastating to kids, so monitoring that and limiting that. Discussing with your child academic interests, career aspirations. How are we going to get you to where you need to be? Do you have the grades to do it? Do you have, the experience to do that? Do you want to try following somebody who wants to do that job? Really kind of getting interest in in what they want to do when they grow up. Vaccines or tests, we have that second dose of the meningococcal at 16. Remember, 16 and you're free. Gardasil 9, we talked about that one in the last slide, depending on your dosing schedule, your yearly influenzas. Unfortunately, as parents, we now have to talk about school shootings and school violence. So being very open with your child about what would you do if that happened, or if it has happened, how do we deal with that? Safety rules for driving, no texting or loud music, setting limits on their phone so that they can't text, limiting the amount of passengers that they can have and the distance that they can go. Anytime they go somewhere, always having a buddy with them, making sure that they have a way to communicate with their parents if they need them. Having that open avenue to discuss abuse, sexual, physical, and emotional, especially now that they've started dating, there's concern about that from their partners. We've talked about the rules, social media, dating, making sure you have a chaperone at a certain age. Smoking, alcohol, and drugs. One way to approach that would say, here's the effects of this, and here's how to avoid it. Here's some things that you could do role-playing wise, so that you don't look like a big nerd saying no, but you can still stand your ground. For sex, we said the average age is 15, talking to them about not feeling pressured, waiting till they're ready, STDs, pregnancy, and then rape. I think that was a great overview of all of our wellness exams, and hopefully that prepared you. There's a ton more to this presentation. If you'd like to buy the package with the full PDF and the part 2 of the review video, that's $60. There's a link at the bottom of the video in the comments section or the informational section that can show you where this is. There's also a 125 practice test question with answer explanations. These are geared to be board level questions, but they can also be useful for your didactic course. There's a clinical pearls matching exercise that also comes with that one. So you can either see this in the link of the video description or at my website. This is just an example of what the clinical pearls matching exercise looks like. It's a drop-down menu to help you quickly associate the questions with the answers. And then this is the appearance of how the PANCE or PANRE test would look. There's 125 questions. There's an explanation for anything that you may have missed. This can be taken once, but it's timed and you can save and return if you don't get to it. I want to thank you for watching this, and hopefully this helped you. I want to thank you for subscribing, and please check out our other videos to complete the PA educational section. Have a great day.